Thank you all for joining us tonight for the Aspen Virtual Think Tank Session 5. Tonight we're talking about minimally invasive spine, and we will give everybody just about 2 minutes to log on, and then we will begin the program. Again, we're going to begin the program in 2 minutes. Thank you all for joining us tonight. We will be starting the program at 6:02 Eastern, 3:02 Pacific to give people time to log on.
I'm Dr. Tim Deere.
And I'm Dr. Dawood Sayed. And we're excited to be hosting the American Society of Pain and Neuroscience's annual virtual conference, broadcast live from Nashville, Tennessee on September 18th through the 20th.
As we come together in Nashville, we'll be addressing several issues that are important to our members and to future members. Things such as minimally invasive procedures for the spine, proper methods of patient selection for interventional pain techniques, and most importantly, safety and efficacy of patients going forward as we progress the field to make things less invasive, more cost-effective, and get better outcomes.
And we want you to join us in what will promise to be the marquee event of the year in the field of pain and neuroscience. Register now to join us.
Oh, welcome. Hello, Dawood.
Hey, Tim, how are you?
Doing well. I'm glad everyone could join us tonight. The last day of the Think Tank, which began as a small little project in West Virginia years ago with 10 people, and now it's grown to over about 1,000 people over the last few nights. So what's on store tonight, Dawood?
Yeah, so this is our closing session of the Think Tank. I think it's been robust and very comprehensive. And this last session today is going to be focused on minimally invasive spine. So I think, for me personally, this has been kind of when I look at how my practice has changed, is how much more things we're doing in the spine that are considered, minimally invasive surgical procedures. So today we're going to have the Boston Scientific and / Vertiflex team talking about interspinous spacers, their evolving role in spinal stenosis, as well as the Vertos Medical team and their group of key opinion leaders talking about redefining the minimally invasive lumbar decompression procedure. And then we'll conclude with 2 really interesting products and companies in our Shark Tank sessions.
No, that's great. We'll finish exactly at 2 hours, right on time. And I'm glad you could join us tonight, everyone. We have several hundred people watching this on the videotape delay, and then yourself watching here live. So with that, we're evolving. We're making things less invasive, with less complications, and hopefully with better outcomes. Dawood, you want to introduce the first session?
Yeah, so it's really a powerhouse session here led by Dr. Pankaj Mehta, Michael Esposito, and Dr. Steven Falowski. They're going to be talking about interspinous spacers, or the vertiflex superior procedure in the role of spinal stenosis.
All right, gentlemen, take it away.
Okay, well, thank you very much, Tim and Dawood. Great introduction as always. It's nice to be bringing us home now at the end of the Think Tank after 2 weeks. Highly successful, thanks to all the work by you two. And it's great to actually open up now with Vertiflex, a great device for minimally invasive option, everything that we look for in the interventional pain space that offers great options for our patients. So I'm gonna kick off this half-hour session by first talking about one is the prevalence of lumbar spinal stenosis. The second is where are these patients in the treatment paradigm with other physicians, and then kind of lead into where does Vertiflex fit into the treatment algorithm. So I'm going to take you across that in the next few slides. I think before we get into that, it's first important to realize the epidemiology of lumbar spinal stenosis. It is one of the most common disorders that we treat in the United States. The majority of people we treat also with chronic pain have some element of lumbar spinal stenosis. We have an aging population, thanks to the baby boomers going strong, thanks to great medicine and medical care that we have keeping people alive longer. What that also means is now we're also obtaining more MRIs in older patients, and we're starting to see more of the diagnosis of lumbar spinal stenosis. We're now also able to offer these patients treatment options, even though they are an aging population and something that we may not have diagnosed previously. Right now, there's over 6.3 million patients suffering from just moderate lumbar spinal stenosis with symptoms of neurogenic claudication. We make that diagnosis in 300,000 to 400,000 patients each year. So you can imagine how this is growing on top of each other. And this is a very large patient population that is highly undertreated. Now, what's interesting about this is when we look at these numbers with lumbar spinal stenosis, we first start looking at how many spinal surgeries are actually performed specifically for lumbar spinal stenosis. And interestingly enough, there's only a few 100,000 surgeries performed. So what is happening to these 6.3 million patients who are symptomatic from lumbar spinal stenosis? We know there's about 1 million epidural steroid injections that are performed, but yet we still have a very large population of patients with neurogenic claudication as well as pain. So this patient population is highly undertreated. And I think part of that reason is because they're in this what we're calling carousel of pain. These patients are bouncing around from different physicians just looking for relief of what they have. And ultimately, it can start with epidural steroid injections, opioids, but then they end up at the primary care physician's office, which they're lucky if they get sent to an interventional pain physician. A lot of times they'll get sent directly to the surgeon who may feel that it's too early in the treatment algorithm or too late in the treatment algorithm for them and send them back to the primary care doctor who potentially sends them to an interventional pain physician. And it's this cycle that happens with these patients constantly looking for some type of relief for what they have. So when we look at the treatment algorithm now, so now we have a good understanding of the prevalence, we have a good understanding of where these patients are in the system and how they're being undertreated. So what are the treatment options? Well, it starts with conservative measures or non-operative measures, which as we know is NSAIDs, muscle relaxants, physical therapy, epidural steroid injections, can also include opioids, which we know we're also trying to avoid after this opioid epidemic that we've had now for several years. And I think we're doing a great job of starting to better treat these patients without opioids. But then previously, the flip side of that was the only other option was surgery, open decompression surgery, open decompression and fusion surgery. There wasn't many options in between to try to take care of these patients, especially address the structural pathology that they have, which is the spinal stenosis. Now we have the ability to introduce an indirect decompression or the interspinous spacer, which is where Vertiflex comes into play. Previously, we didn't have these options. Even the spinal surgery options that were considered less invasive were usually open surgical type procedures. Most people are most familiar with those type of procedures, which were not very minimally invasive, such as like the X-stop procedure. So moving on to the next slide, what we'll see is when we take it through this treatment algorithm, so you have the non-operative care, which is usually the mild stenosis patients, don't have any pathology such as a spondy. And then you move on to the patients who have started to have progression. So now they're in that mild to moderate category, maybe even the moderate to severe spinal stenosis category. Can include all three, meaning central, lateral, and pyramidal stenosis. Have less than a grade 1 spondy, but maybe starting to develop an ampulothesis or retrolisthesis. That's where the Vertiflex procedure comes in. That's the idea of this minimally invasive procedure that doesn't require open removal of bone or open removal of bone with a fusion, which is where we get into the severe category. Now, when you look at this progression or treatment algorithm, it's important to realize that Vertiflex is actually used mostly on patients who are not surgical candidates. So what that means is they're in that mild to moderate category of spinal stenosis. They may have central, lateral, or pyramidal stenosis, but symptoms of neurogenic claudication. However, the surgeon may think that they're too early in their pathology or their symptomatology to intervene with an open procedure. That is a perfect opportunity to introduce Vertiflex to these patients with the hope of actually preventing them from moving on to need further spine surgery. The other side of that equation is the patients who have a lot of medical comorbidities, advanced age. Those are also the patients who are going to be turned down for surgery as not being surgical candidates. Those are also now great candidates for the the Vertiflex device. So what's interesting is now it's important to realize that by offering this device to your patients, you're not necessarily stepping on the surgeon's toes. In fact, it actually works in collaboration with them, because it's usually going to be before they would be surgical candidates or when they're no longer surgical candidates. Next slide. So some of the important features I think about this is that, and this is what I usually talk with interventional pain physicians about to talk with their surgeons, is not only are you not stepping on their toes, you're not necessarily taking their patients. To begin with, we're only doing a couple 100,000 spine surgeries when there's over 7 million lumbar spinal stenosis patients that are symptomatic. So this is not a matter of stepping on their toes to take patients. The other idea is the idea that you can now no longer have a virgin spine. What we see with the Vertiflex devices, there's no bony removal. You don't create scar tissue. This is actually placed in between the spinous processes. If you imagine the worst case scenario is it does not work over time. So as we know with the data, which Dr. Esposito is going to go through, we have an 80% chance, at least even up to 5 years, that this will prevent you from moving on to have a further spine surgery, which I think is astronomical for a minimally invasive procedure of this type. But even if the patients fall into that small category of 20%, the question is now, have you burned any bridges? And the answer is no. The spine surgeon can still go in and have an absolute virgin spine for the patient, and these are easily removed, especially with open surgery. We also know that with open surgery, over time, laminectomy has a high reoperation rate. That's for a lot of different reasons: recurrence of the stenosis, scar tissue formation, or even spinal instability that comes on over time. So you're no longer burning the bridges of not having a virgin spine. The other thing is pointing out is the low complication profile that comes with these patients with the putting in this device. We know that now interventional pain physicians are very inept and very skilled at doing these type of procedures, and have demonstrated not only in the study but the press registry after market release that the complication rate is extremely low, and this is very safe for patients, especially being outside the canal and outside any type of neural compromise. So on the next slide, I'm going to pass it on to my colleague, Dr. Esposito, great colleague to work with, and has really built up a great name for himself in the field, and has worked a lot with Vertiflex, and he's going to present the data for Vertiflex.
Thanks, Steven, for the kind introduction, and I think you did a great job laying out and illustrating what the issue is and how many patients in our country suffer from this disease, and where Superion really fits in the treatment algorithm for spinal stenosis with neurogenic claudication. So I think you laid it out very nicely, and the great thing about the Superion and Vertiflex procedure is that it allows for a favorable neural pathway dimension, right? So the neural pathway, the spinal canal, the lateral recesses, and the foramina are actually improved with the Vertiflex procedure. And Steven actually did a very nice study and had published this review and cadaveric study last year in Pain Medicine, and I certainly recommend all of you to search that and take a look. It was really eye-opening. And so if we move on to the next slide, we're going to go over the effect that Vertiflex has on these different dimensions. But first, I think it's important to recapitulate our understanding about how Superion is meant to work. And it's an indirect decompression, but really what we're trying to do is limit extension, right? These patients with spinal stenosis are the ones that demonstrate the shopping cart sign, right? They're getting relief in flexion, or when they're seated in flexion, right? And so what we're trying to do is limit the extension that these patients have that cause these symptoms. And why is that? Well, if you look, in this middle column, what we see is that patients who are in extension, that the area of the central canal actually decreases, right? And so this is a structural issue, and this decreased area causes pressure on these nerves, which then causes the symptoms. Same thing with the foraminal area and the ligamentum flavum. Actually, the thickness increases in extension, whereas in flexion, we see these biomechanical changes, right? Why do patients get relief of their symptoms in flexion? Well, it's because the area of the canal, the area of their foramen are actually increasing. And believe it or not, the ligamentum flavum thickness actually decreases in flexion. Think about kind of like a rubber band getting stretched out. And so in this in this study where Steven and his colleagues looked at the impact of superion in the biomechanics of cadavers, what we saw was that with the superion in place, and when we tried to extend those lumbar spines, the canal area actually maintained an increase in area as compared to a cadaver who is in extension without the superion. So we also saw this in the foraminal area, and we also saw that the ligamentum flavum thickness also maintained a decrease in thickness. So the Vertiflex procedure and superion actually has these biomechanical favorable impact on the neural pathway. If we move on to the next slide, what we see is that from that cadaveric study, that the superion doesn't just treat central spinal stenosis, but also takes into account the foraminal zones and the lateral recesses, although those may be a little bit harder to measure. And what do we see in practice, right? We rarely see patients who just have an isolated central stenosis or an isolated foraminal stenosis. Oftentimes these patients who are presenting with this failing back and with this spinal stenosis, they have multifactorial stenosis. They have the central stenosis, they have lateral recess stenosis, they have foraminal stenosis. So what we know is that these patients often are going to benefit from superion by having an impact on affecting all of these zones of the spinal canal. And so what does this mean in real life? Well, if we move on to the next slide, we're going to talk a little bit about the data that's available. And so many of you have probably reviewed this before, but if we look at the IDE study, which I think it was quite impactful, not just in what it examined and what it compared and the results, but the fact that the arm that looked at the Vertiflex patients was carried out to 5 years. Very rarely do we have 5 years of data. But the study design for this approval study had almost 400 patients, and what they compared the superion device to was the existing X-stop. And obviously it was across multiple sites throughout the country. It was randomized, it was blinded, single-blinded, and the outcomes that we looked at were primarily the Zurich claudication questionnaire, the ZZQ. And I think what's so impactful about this is that it really looks at functional measures, right? We hear this more and more these days, that we're not just focused on the pain score, because what does a pain score mean if the patient really isn't functioning better? And so this, I think, is one of the strong points about this study, is that it looked at this ZZQ, which looks at function. And so we followed this and secondary outcomes like the VAS and the ODI and the short form health survey and the radiology, and we followed these patients and we looked at them at 2 years, 3, 4, and 5 years. After 2 years, the FDA approved the superion for use in the general market. But again, the Vertiflex arm was followed out to 5 years. And so what did we see in this? If we go to the next slide, we'll talk about some of the outcomes. And that is that over 5 years, when we look at claudication symptoms, patients demonstrated a 75% improvement in the pain in their legs, a 2/3 improvement in the back pain that they experienced. And then looking at function, they had 85% of patients were able to reduce their opioid burden. Again, as Steven said, in this day and age of the opioid epidemic, we're looking to have these interventions and these treatment options that decrease the opioid burden for our patients. And then very rarely do we see in anything that we do such a high satisfaction rating by patients, and 90% of patients were satisfied with the relief and the improved function that they obtained over 5 years. So we certainly see this durability of improvement, and both in pain and function. And if we go to the next slide, this really leads to more questions, right? Well, sure, you say that this was in a controlled setting, right? Well, what is life really like? What are the results out there in the real world? And the fact is that Vertiflex in Boston, they put together the PRESS registry, which really looked at real world outcomes in the hands of pain physicians all over the country. And if we move to the next slide, what we see is that the results were recapitulated from the IDE study, and that functional improvement was maintained, VAS scores were maintained, and patient satisfaction was maintained. So it makes me feel very confident when I walk into a room and discuss the treatment options of spinal stenosis to tell a patient, hey, there's an 80 to 90% chance that you're going to be satisfied with your results. You're going to have a functional improvement, and you're going to have improvement in your pain. So 4 out of 5 chance, or 9 out of 10 chance that you're going to have this improvement. And this data was published, 12-month data, and the registry continues. So it'll be interesting to see how this real-world data draws out. So just to summarize, right, we have an FDA approval based on a level 1 RCT with 5 years of outcome data. It's one of the largest trials that we have looking at lumbar spinal stenosis treatment. It's been published in multiple journal articles, and true to the saying, no money, no mission. This has a Category 1 code established for reimbursement purposes for the practice. So with this compelling data, I'd like to turn it over to my colleague, Dr. Mehta, to talk about how we identify patients that will benefit.
Hey, thank you. Sorry, I was muted. But my name is Pankaj Mehta. I'm going to be talking about the tail end of this talk. One of the key things which Dr. Falowski mentioned was, I think the really take-home message from his talk was about the prevalence of lumbar spinal stenosis in our community, in our city, in our state, in our country, and globally. And I think this is something we really need to be mindful of. What Mike said is so crucial, that you have to look at evidence. And I think the evidence is very compelling about using therapy like Superion, especially when you promise this to the patients and tell them that the real world scenario actually mimics what the level of an evidence shows. And we've seen some of the drawbacks of this philosophy of a real world scenario mimicking the level 1 evidence in certain therapies. And I think this is where Vertiflex stands out, where you can really promise the patient. But then the question is, who is that patient in your practice? I've been to so many practices, spoken to peers and colleagues, and even within my own practice for the first couple of months when I embraced this therapy, the question really to myself and my team was, who are those patients, and what is the diagnostic algorithm for using a therapy for symptomatic LSS? And just to kind of sort of summarize in one quick slide before we move on is, if you have a radiographic evidence of lumbar spinal stenosis, the next question really is that symptomatic? And if the answer is yes, then the next question should be, does this patient get relief in those symptoms when the patient sits down, or any format of flexion, such as using a cane or a walker, or sitting down, or leaning on the countertop, resting between daily functions in their house or life. And if the answer is yes to that, then you know that if you actually provide an extension blocking effect on that patient at that level, where the patient has radiographic evidence of stenosis, then this patient will benefit from this therapy. But before you proceed on to schedule this patient, you want to quickly rule out the contraindications, right? You want to make sure that the patient actually qualifies for this therapy, and all the relative and absolute contraindications are being looked at. Then really the last question is that, how bad is the stenosis? Does this patient qualify for a surgical exploration, or is this something where our surgical colleagues will not operate, such as high-risk cases, or maybe it's a symptomatic mild to moderate disease? And all of these things form the algorithm in your practice. Next slide. So again, if you actually take this algorithm, which I just mentioned, and you basically put it in the form of a flow, you will find that it will become easy to identify LSS or symptomatic LSS in a practice. And again, this slide is not the algorithm, but it is suggestive of a skeleton algorithm, which you can adopt in your practice and look at your patients day to day who come in with back and leg pain. And why do we need to have an algorithm? Because one of the things I realized in my practice is nobody walks in your practice with these stamped diagnoses of spinal stenosis. Patients walk in with symptomatic diagnosis, which means that patient will walk in with back pain and leg pain. And one of the things we do as physicians, as pain physicians, is triage the pain generators and then come up with a working diagnosis. And I think that's really where LSS actually gets embedded between those confusing symptoms which patients walk in with back and leg pain. So the onus is on us to dissect the pain generators down and move on this algorithm which you just see, and then ask these questions yourself. Has this patient failed conservative care? Like most patients would come in my practice who have probably had physical therapy, have had short-term relief, patients probably had some interventions in my own practice with my own partners, or maybe coming from a competing practice or the next door practice. Ask yourself, this patient has severe stenosis. Patient is symptomatic. Why is this patient not a surgical candidate? Is this patient got high surgical risk? Is this patient got some comorbidities which could prohibit this patient from undergoing extensive surgery or an extensive fusion? And then the question is, if this patient has already had a structural surgery and a fusion and has had a direct decompression at a level, because of the fact that the patient has an immobilized segment in the distal part of the spine, the adjacent segment, is that crumbling? Is that leading to or giving birth to a new segment of spinal stenosis, which could be symptomatic and be responsible for the patient's symptoms? And if the answer is yes, then you need to have an algorithm for that. So it all comes down to what's that core classification or core algorithm which you need to keep in mind as you're busy in your practice with your nurse practitioners, with your colleagues, and seeing follow-ups for 15 minutes. And we all take pride in how busy we are and how loaded our schedule is. But I think it is important to have a cheat sheet, right? So you want to make sure you focus on the patients who have failed conservative care, who have not got relief from other interventions, who may be high surgical risk, and patients especially who have had failed back surgery syndrome. Why do we focus on patients with structural surgery or failed back surgery syndrome? Because we are all high quality interventionalists, and we do a lot of spinal cord stimulators. We have a lot of neuromodulation therapies in our practice. And guess what is the #1 indication of spinal cord stimulators in our practice? It's failed back surgery syndrome. So when a patient walks in with structural surgery or structural immobilization of the spine because of a fusion, we need to start thinking about, why is this patient still symptomatic and what else is going on right above the level of the fusion? And again, it goes back to then looking at the study, looking at the robust data, which Mike mentioned about how good the back pain improved, 75% improvement in the leg. But more than that, while we are all working as part of society, as part of in the community, as colleagues and peers, we all talk about how can we curb the opioid abuse or the opioid overuse in our community. And all of this is one step forward which will help us reduce the consumption of opioids, especially in these patients with LSS who technically contributed to a roadblock in our practice, and the data shows that. Again, other interventions, right? So Tim, myself, and a few of us presented this at NANS, I think it was a couple of years back or 3 years back, where we showed that what is that number one frustration which most neuromodulators have or see in their practice, that there are a lot of therapies which do great, and no matter what company it is, but that a time comes when a spinal cord stimulator ceases to function to the expectations of the patient. It doesn't mean that the therapy has failed. It doesn't mean that the company has failed. What it means is that we still don't have a robust algorithm as to how do we then work this patient up from testing microfractures to lead migrations to tolerance to are there any other parallel pain generators. And one of the things we saw in our practice and Tim saw in his practice was that a lot of these patients who we basically labeled as having inefficacious spinal cord stimulator therapies were in a sense were not feeling the benefit of the therapy because of adjacent or a parallel pain generator. And so what we did is we treated their claudication and leg pain by indirect decompression or putting an interspinous spacer device. And lo and behold, these patients got better instantaneously in their back pain and their leg pain. And clearly, whatever residual opioids they were on, despite stimulation, neuromodulation, we were able to get rid of that. Again, the same thing with high risk, high surgical risk. Dr. Naidu and myself presented this at INS last year in Australia, where we showed that there are a lot of patients above the age of 85 and 90 who, because of their age or other comorbidities, were not able to undergo surgery. And despite the fact that they had symptomatic late moderate, maybe early severe stenosis, in consultation with our surgical colleagues, we went ahead and treated their symptoms with a spacer. And you can see clearly here the improvement in back and leg pain. Next slide. And again, like I talked about, right, one of the key things we need to really focus on is what is going on when you immobilize the spine. And a lot of things happen. The force of the vector, which is the natural force of the vector, changes direction and dissipates away from the spine or gets slowed down when it leaves the fusion. And so without going too much into physics, what we did is we started treating adjacent segment symptomatic lumbar spinal stenosis and put in spacers as long as there was a viable spinous process. And what we saw is that people who had adjacent segment disease, with or without stimulators, did way better than if we had left this untreated, or patients were afraid of having surgery. Sometimes the surgeons didn't want to extend the fusion, and a lot of these patients did well. You can see almost an 80% improvement in leg pain. Next slide. And again, it all comes down to, you see, a robust data because of why we should choose this therapy. The fact that it actually works on lateral recess and foraminal stenosis. It is very important to understand the prevalence of LSS in your community and your practice, like Steven said. And again, if you're wondering, where are these patients? I don't have spinal stenosis in my practice, or why is my stimulator not working, or why am I frustrated? Despite the fact that an efficacious therapy of spinal cord stimulation is going on in people who have had back surgery before, failed back surgery syndrome, you need to start thinking about a parallel pain generator, such as symptomatic spinal stenosis. But here are the advantages, like Steven said. There is no resection of tissues. So when you talk to your surgeons, they're not worried about you violating the integrity of the spinal column. The fact that you can actually help these patients with central stenosis, lateral recess stenosis, and foraminal stenosis in a ripple effect at that level, I think speaks volumes for this therapy. And like Mike had mentioned, that this is not a 5-on-10 approval. This is it's a FDA approval based on a level 1 RCT. And while we are all focusing on an evidence-based embracement of new therapies, I think it's very important for young neuromodulators, young implanters to understand this concept. Next slide. So based on all of these things, one of the things I want to quickly mention is about Boston Scientific. When Boston Scientific acquired Vertiflex, really the first thing which was offered to interventional pain physicians was a combination of a portfolio therapy. And the portfolio therapies encompass spinal cord stimulation, radiofrequency ablation, and Vertiflex now. But what was the whole reason, or why should one start looking at a portfolio bracket of therapies. It's because if you look at this Venn diagram, that's the patient we see in and out. That's your 65, 70, 75-year-old gentleman who's coming in your practice who has mostly three broad groups of pain generators. They have a bad disc leading to radiculopathy and maybe neuritis or radiating neuritis or painful neuritis. They have some axial back pain because of facets. And we always knew that, and we always treated those with spinal cord stimulation and radiofrequency ablation, alternating one with the other or with epidural steroid injections. But we really never had a robust therapy for the third Venn, part of the Venn diagram, which was symptomatic LSS or neurogenic claudication. And fortunately, there's one company now which offers all of these three. And so based on medical necessity, I think most physicians now have the luxury to choose or focus on each pain generator having its own implantable therapy. Next slide. And that's it for Vertiflex. Thanks, Tim.
Well, thanks, Pankaj. I think we're going to start with just a few questions. I think Dawood has a question for Steven first. Dawood?
Yeah, Dr. Falowski, I think this might be very similar to the question I asked you when we were talking about minimally invasive SI fusion, but it's more of a political question because, again, we're going to have, hundreds of people, if not thousands, that are going to watch this, interventional pain doctors that'll want to incorporate this procedure into their practice. And there may be some political opposition from their surgical colleagues, either within their own institution or their own practice. What is your advice for someone like myself or Pankaj or Michael when they're trying to approach their surgical colleagues when they want to incorporate this?
It's a great question, Dawood, and I think it really fits into the state of pain care right now, and that is that interventional pain physicians are starting to do more and more. We're starting to realize that their skill set is capable of that. The field has pushed towards minimally invasive procedures. I'm somebody who's dual trained in complex spine, lumbar fusions, thoracic lumbar fusions, but I'm also trained in procedures like neuromodulation, spinal cord stim, Vertiflex. So I tend to see it from both sides, and I think it's important for surgeons to realize that this change is coming. The skill set of interventional pain physicians is there, and they're going to start doing these minimally invasive procedures. Now, on the flip side, I think to my fellow colleagues here too with interventional pain, the discussion with the surgeon is a matter of educating the surgeon. Unfortunately, most surgeons view these type of procedures as something like X-stop, which was an open surgical procedure with a two-piece implant. And that's what they think interventional pain physician is doing now. But that's not the case, as we went over today. So I think that the key is educating the spine surgeon and educating them on three aspects. One is that it's not that you're going to have complications that you can't deal with and you're going to have to call in the surgeon. Two is they're still going to have a virgin spine. So in the worst case scenario is your minimally invasive, low risk profile procedure doesn't work. And that's the worst case scenario, and they still have a virgin spine to go to. And then finally, the last thing is that you're not stepping on their toes. You're not taking your patients. It's the patients earlier in the algorithm or later in the algorithm. Both of those they're not operating on.
Great answer.
Even those are great points. Thank you for that. I think we want to do what's less invasive and more cost effective, but also efficacious. And that leads we have two last quick questions for Pankaj and Michael. Michael, the question for you is this, I've always been told, we've been doing Vertiflex since the study. We were part of the study. I think we're the only non-surgeons in the study. But, let's say you have a level at 3-4, that is the worst level, but they're also bad at 4-5. So I've been told by some, do the lower level first, and I've been told by others, do the worst level first. How do you make a decision which level to do first in a 2-level Vertiflex implant?
Flip a coin. No, I'm kidding. The way that I do it is I'll actually take some scout images and I will look to see which interspinous space is narrower, and then on the lateral also to look and see which part of the spinal laminar line is more ventral. And that's the level that I'm going to do first, because I want that spacer, that superion that needs to sit as far ventral as possible to be put in first. So I'm going to do that level first, and then I'm going to go and do the next level. Usually the more superior level and or the most severely stenotic level is the one that I'm going to choose to do first.
I think that's great insight, Michael. I think that lateral view is so important. Pankaj, last question of the session. It goes back to a point you made about a study you and I did together, but it's important. Let's say a new patient comes to see you with stenosis, failed conservative care, has moderate stenosis at a couple of levels, definitely a candidate for an interspinous spacer, but they also have a previous back surgery at 5-1 with radicular leg pain in the left leg. Which do you do first, a stimulator trial or an interspinous spacer, knowing that they may need both?
Yeah, it's a great question. I think it's something we really all see in our practice. And to start off with, one line answer is they may need both because we are treating two separate pain generators. And my algorithm in this case, Tim, is that I discuss with the patient that there are two separate entities, two separate pain generators, which may need its own implantable therapies. And what I do is I will do a Vertiflex first. And the reason I do that is because I place my IPGs a little higher up. And so, if you don't do the Vertiflex first and you do the stimulator first, then and you end up doing Vertiflex, the entire action is under lateral fluoroscopy, and sometimes it's pain in the rear by somebody has to push the IPG away, especially if you're targeting lower levels 3, 4, 4, 5. So it's just been my sort of practice philosophy to do Vertiflex first, kind of indirectly decompress it, and then I'll do a stimulator trial and an implant, space it out over a few weeks.
No, I think that's really great advice. Gentlemen, thank you so much. This was a wonderful session. We greatly appreciate all three of you and look forward to seeing you in person, hopefully sometime soon.
Thanks, guys.
Dawood, you want to introduce the next session?
Yeah, so we're going to pivot just a bit, still focusing on the same disease entity, spinal stenosis, but an alternative way to address it. So we're going to have our team, the key opinion leaders from the Vertos team, talk to us about redefining the mild procedure, emerging techniques and advancing the treatment algorithm. We'll have Dr. Pope, if he can make it. I think he might be running a little bit late. Dr. Escobar, Dr. Patterson, and Dr. Weisbein. Dr. Escobar, can you please kick off for us?
You're on mute, Alex.
Good evening, everyone. Excited to be here with you all. I do believe Dr. Pope cannot make it, so you get the blessing of having me do his section. Excited to talk about redefined surgical technique and treatment algorithms for using minimally invasive lumbar decompression in your practice. When you identify patients with lumbar spinal stenosis, as we've all addressed here, we want to really look for the root cause and whether or not there is ligament and flavum hypertrophy. We have a very effective technique to address the cause of the problem without leaving anything behind. To the right patient. And so what I commonly hear in practice when I'm training physicians and discussing this treatment option is that even physicians who have had success with the technique in the past have sort of abandoned the therapy due to some misconceptions. We want to clarify that because I, since fellowship at the Cleveland Clinic, have witnessed this therapy be extremely effective and safe for patients with ligament and flavum hypertrophy and symptoms of neurogenic claudication. Next slide. So we really want to focus today's session on the emerging surgical techniques as well as the algorithm in place for the use of minimally invasive lumbar decompression. It is well established that the mild procedure has scientific evidence and a large body of experience. The Midas Encore RCT has demonstrated statistically superiority of common treatments we use for lumbar spinal stenosis, albeit some may not believe epidural steroids are the treatment of choice for neurogenic claudication. It is common practice in all pain specialties to use epidural steroid injections in the face of stenosis, whether it's to treat the radicular symptoms or symptoms related to the pathology of neurogenic claudication. So therefore, what do we find when patients continue to seek or continue to use the similar techniques of efficacy is that these patients seek alternative care, and they'll go to another specialist or another practice if they aren't able to effectively address their symptomatology. I think the most important part of this is to identify the safety profile of the mild procedure, in that many of our patients have undergone epidural steroid injections. And we've seen with valid evidence that the safety of the mild procedure is no different to that of an epidural steroid injection. And the most common thing or concern would be an inadvertent dural puncture, which when performed safely and effectively is not a concern of ours. Therefore, you can confidently tell your patients that the risk they assume with this technique is no different to that of an epidural steroid. Next slide. So as mentioned earlier, and I think it's critically important in our specialty that we measure and track outcomes data. And seeing that data beyond 1 year is rare. I applaud all companies and all physicians to continue to move this specialty forward by tracking these outcomes. And we want to advance this technique by really exposing you tonight to the single access technique, which has been developed by many KOLs within our space to optimize time, to reduce fluoroscopy exposure or ionizing radiation, and offer a more convenient and streamlined approach to both physicians and patients. We know that the mild portal is less than 5.1 millimeters. Therefore, we're able to successfully treat bilateral spinal stenosis with a single entry, single access point, leaving less time to have to create those extra incisions and an improved patient experience. I can tell you from experience that all of my patients who have undergone a minimally invasive lumbar decompression experience minimal to no post-procedural pain. In fact, I commonly employ a routine epidurogram at the end of the case and ensure adequate epidural spread, and then use epidural steroids to help minimize any post-inflammatory response, which helps in that. So we encourage our patients to stay active. We want them to move to improve. And in that, we don't just look at this as a definitive treatment that requires no other factors. Therefore, physical therapy and core strengthening are all things that we employ post-procedure, which our patients can do quickly. Next slide. So one of the things that Vertos Medical has done exceptionally well is really listen to practicing clinicians. One of the many features that we see with innovation comes around optimizing techniques and not recreating something new. And what we've found through many hours spent in the cadaver lab, as well as employing this streamlined technique in many of our practices, is that we can commonly access both sides of the lamina using the single entry point that we will see in a video shortly. This allows, again, for minimal procedural pain, for improved time and efficiency, and as well as the lack of the need for prolonged ionizing radiation exposure. So at one of these training sites, we, thanks to Dr. Chapin, have really explored and refined the technique of the single access or single incision technique. By utilizing the single access point, we are using the cannula to really direct to each side. And we'll show you here in this video to come, next slide, what that looks like. So how you want to utilize this is identifying the treatment level, the targeted treatment level. Typically, we could start play. Typically starting about 1 to 1.5 vertebral bodies below. We utilize a spinal needle finder to identify the trajectory and access. And after making that single access entry, we use a lot of torque and drag on the cannula to identify and to treat the ipsilateral side that you'll be addressing. I recommend that while you're doing this, you are changing views, so going from AP, as we see here, to ensure that you're not crossing the midline and that you're accessing the interlaminar space at an appropriate angle. Almost all of our patients now being treated with mild are being employed this single access entry site, which has created a vast reduction in radiation exposure as well as time and efficiency. I think another thing that can't be overstated is the fact that we can optimize and use this procedure without the need of a sales rep or force and treat multiple levels simultaneously while still keeping ionizing exposure at a minimum. Typically in my practice, I see about 1.5 minutes or less of fluoroscopy time, as well as less than 50 milligrays of exposure. Therefore, we hope that you can come to find that this single access entry should reshape how you utilize this procedure, and also encourage you to optimize and offer patients with evidence of ligamentum flavum hypertrophy the minimally invasive lumbar decompression. We could field questions or.
Hey, Alex.
Hey.
So tell me about your outcomes with, you've incorporated this streamlined technique now, I believe over the last few months since our kind of redefining this procedure several months back in New York. How have your outcomes been?
So in my practice, using this approach, I think as far as the efficiency of the procedure itself, phenomenal. As I mentioned earlier, the radiation exposure as well as the milligrays that we're using are minimal. The patient outcomes from day one have been successful, and I've seen about, similar to that of other techniques, about an 80 to 90% satisfaction rate, which is critical. Looking at this as a functional restoration, we are tracking the amount of time patients are standing and walking, and we've seen that about 70 to 75% of patients are seeing at least a doubling, if not tripling of that time, as well as a reduction of the ODI of at least 10 points. So we're continuing to track it, but I find that patients are recognizing this as an effective treatment and telling many members of the community.
Alex, before we get to Dr. Weisbein, I have just one more quick question for you. So, you were in West Virginia. I still have a great picture of the two of us together here. And we talked about the single incision technique, and I've really gone to that. And our radiation time's been cut in half. For those fellows and residents who've never seen this procedure before, that's a big difference, because we used to make maybe 4 incisions if you did 2 levels bilaterally. My question for you is this: have you changed the way you do the epidurogram? Because I know I have, but I want to see how you're doing your epidurogram now for that procedure, and then we'll go into Dr. Weisbein.
So traditionally, when I was in fellowship, we would do an epidurogram at each level, at each ipsilateral side. I found that to be too cumbersome, and with the use of our safety landmarks of the spinal laminar junction and the contralateral oblique view, I employ a single epidurogram and try to get it at the apex and as close to midline as possible. And the only time I'll reserve accessing a different entry point is if I lose that epidurogram, because I will be utilizing an epidural steroid injection at the end of the case. So I use a single epidurogram for every case.
No, I think that's very helpful. Awesome. We appreciate you very much. We'll maybe have you back at the end, but I think now we go into Dr. Jackie Weisbein. Jackie?
Good job, Alex.
Hi, guys. Thank you so much. Alex did a really great job explaining everything about the new procedure algorithm, which has been really amazing. I think I also have the benefit of following my colleagues, Steven and Michael, who spent a lot of time talking about neurogenic claudication. So we know when these patients are presenting to the office that they're coming in complaining of that weakness and low back pain radiating into the lower extremities, that when they're up and walking, and they really can't walk for any period of time unless they are bending forward or sitting down. And the key thing is that these patients do get relief when they bend forward or sit down, because if they're not getting relief with those kind of activities or changes in activities, they might not be someone who's really truly exhibiting signs and symptoms consistent with neurogenic claudication. One of the most beautiful things about being able to look at your own imaging is, specifically for these patients, when we're considering mild, we want to see that there's hypertrophy of the ligamentum flavum beyond 2.5 millimeters. Anything beyond that means that patient is a candidate for this treatment. And so moving forward, it's important that you understand that even though patients may also have foraminal stenosis, if they have central stenosis that is indicated by this hypertrophic ligamentum flavum, then they are a candidate for mild. Additionally, you want to make sure that there's less than a grade 2 spondylolisthesis so that you don't have to worry about any kind of spinal instability. Next slide, please. So again, things that we want to think about. Most of us, like Alex was talking about, when patients come to our office, they're typically patients who are having neurogenic claudication, and the first thing that we offer them is an epidural steroid injection. When I see this for my patients and they come in, I'll talk to them about mild. I'll give them the booklet or the brochure about mild at the same time while I'm actually scheduling them for an epidural. But I tell them that the epidural is not necessarily 100% predictive if they're going to actually get relief from the procedure. So ideally, I'm trying to buy them a little bit of relief, but I tell them again that even if it's not long lasting or it's not as efficacious as we'd like it to be, it doesn't mean that they aren't going to have a successful outcome with mild, because we look at, again, that hypertrophic ligament to see if that's really what the major compression is coming from. Now, in these patients, we also have things where they see hypertrophic facets or a disc bulge complex in addition to that hypertrophic ligamentum flavum, but being able to reduce a significant amount of that tissue in the posterior aspect allows there to be some more room for those nerves rather. So as they're walking, they don't have that compression from the pressure of everything while they're standing up. Next slide. So again, thinking about where these things fall into place. So when patients come in, again, I'm giving them that mild booklet as I'm thinking about scheduling or actually scheduling them for an injection. I work with a spine surgeon, and so, to the comments earlier about wondering if this is something that our partners or our colleagues might find difficult as a part of the algorithm, I think of this for many of my patients who don't want a large surgery or aren't looking to be in the hospital overnight. It's very easy for them to do this as an outpatient under minimal sedation. Also, if these patients have any degree of osteoporosis, I don't worry about damage to their bones when I'm performing mild. And having trained when I first left fellowship and now seeing this new streamlined technique that's been evolving, I find it to be something that really is simple for the patients to tolerate and give them the great results they're looking for without the large invasive surgery that my partner might have to do for them. Next slide, please. With that, I think I pass it after this to Denis, who's going to talk a little bit more about the data. But what we want to see is that the most important thing for us to talk about is that this is exactly a procedure that is safe and efficacious, and it has a similar profile of safety to epidural steroid injections. And we can see that the amount of adverse effects regarding procedures or device-related adverse events is approximately 1.3 in both epidurals and in mild. And there's really been 0 reported adverse events. Again, we don't have any issues with seeing any spinal instability developing when we take out small pieces of the ligamentum flavum with this procedure. And additionally, we've had 0 issues with any spine fractures over the past 2 years when we're decompressing that ligamentum flavum. So both really important things, particularly for our patients who are elderly and have, like I said, osteoporosis. So next slide, I think, is Denis on more of the data.
Hey, good afternoon, everyone. How are you guys doing? So I've got a single study or a single center study by Dr. Bolkowski from Levis Pain Management in New Jersey and Pennsylvania. And basically, what I like about this study is that it highlights how the data that Dr. Escobar went over in the Midas Encore study, how this translates into the real world. So, a lot of times we do studies, the criteria on selecting patients is so strict that, you get a good outcome there, but when it translates to the real world, sometimes you don't get as good as an outcome. So it's nice to take a look at your own patients, retrospectively see if you're getting the same results that you see in the studies that were done formerly. And so we've got a single center here, and what we have is 47 patients, and we see it's predominantly female, 66 compared to 34% for males. What I like about the study is that it also tracked spinal cord morbidities. So I think, with the mild procedure in the past, we were all looking for unicorns, patients who had central canal stenosis only due to ligamentum flavum hypertrophy with no other sources contributing to the stenosis. But what we see here is that and what we've learned from the Midas Encore study is that there's multi-factorial stenosis in these patients, and there are multiple comorbidities resulting in the stenosis. So it could be In this study, we saw that all patients had ligamentum flavum hypertrophy to be a candidate for the study. But on top of that, majority of them had bulging discs, facet arthropathy or hypertrophy. They had foraminal narrowing and lateral recess stenosis as well. And when you look at the levels treated, you see predominantly the levels treated were L3-4 and L4-5. And I think if we all look at our own clinical practice, we'll see that majority of the levels that we're offering patients either some type of spinal stenosis intervention where majority of the time we're targeting those levels. So this seems to be pretty accurate with what we see in our own clinics. And what's interesting enough is that when you take these patients and you look at results based off of, did this patient get an epidural before moving forward with the mild, or just one epidural before moving with mild versus multiple, what we see is there's no difference in outcomes. So if you look at patients who got one or no epidurals, we see that there is a significant drop in the VAS 3 months after having the procedure. And then when we see that patients who got multiple epidurals before being offered the procedure, we see the same outcome. And so what I think this leads to as a conclusion is, should we consider moving mild up in the algorithm, meaning that should we offer them the procedure knowing that they have neurogenic claudication as a source of their symptoms without doing an epidural steroid injection first? And I think that's what a lot of us should consider in our practice. To me, you know, I think of several reasons to do it, or the only reasons to consider an epidural is one, confidence. You know, if this is the first time you've seen a patient, you've never done a procedure on them before, you may want to build confidence with them by doing one epidural to give them short-term relief. Two, some of these patients are going to come to your clinic, they're going to clinically have neurogenic claudication, you're going to have access to an imaging report, but unfortunately, you know, several times I've seen the radiologist doesn't mention ligamentum flavum hypertrophy, and I physically got to track down the films myself. I got to measure to make sure that they got greater than 2.5 millimeters of ligamentum flavum hypertrophy before being able to offer them the procedure. So I may want to do an epidural steroid injection just to buy me time. Three, patient preference. Maybe this patient is not interested in moving forward with a mild procedure or something that they would see as more invasive, and they're wanting to try an epidural, so that would be another scenario to do it. But if those three factors aren't a factor, what I see is a lot of these patients have seen multiple physicians, they've had multiple epidurals over the years, and the reason why they changed providers is because they weren't getting long-term satisfactory relief. And so in this case, why would you want to make the same mistake that their other providers did and just offering them epidural and not offering them a higher level procedure like the mild procedure, which has shown to be just as safe as moving forward with an epidural out of the gate? Next slide. The last scenario, and this kind of goes over what we're saying, is that in those scenarios, I think moving forward with, you know, these patients, they've got clinical neurogenic claudication, you've got imaging shows they got ligamentum hypertrophy. We know mild is less invasive than putting hardware in their spine with an interspinous spacer or doing a lumbar decompression. Why not consider doing a mild without doing an epidural from the initial consultation? Then, as I was saying, the second, if there is a reason that to consider an epidural, one, it'd be for short-term pain relief while I build confidence with the patient, track down imaging, or three, next slide, look at doing a CLO view when I do my epidural for diagnostic and or pre-surgical planning to move forward with the mild procedure next on the patient. I think a lot of times while we're trying to track down the imaging, we can do this epidural and we can see the thinning of the epidural space at the level of interest and see that there's ligamentum, flavum hypertrophy buckling into the epidural space, and then also gives us more information on how to pre-plan for doing the mild procedure down the line. Next slide. And I think that's it. I think invite Dr. Escobar and Dr. Weisbein back on for any last second questions.
Yeah, Dennis, let me ask you a question. I've done the mild procedure now for almost a decade and found it to be a great procedure, and it's really gotten better. My question for you is really, I think, a complicated one. So let's say you have L3-4 ligament inflammable hypertrophy, and you want to do a bilateral mount at that level, and you're worried about that being pretty stenotic. Do you do your epidural at the same level, or do you go a level above because of the stenosis at the level of treatment?
Yeah, what I have noticed is that, just like Dr. Escobar was saying earlier, that a lot of times doing the epidural at the level of interest can just get in the way of using your instrumentation. And so I believe that going at the top of or the apex. So I will go a level above, do the epidural at that level, try to get an epidurogram. And, I've done so many of these now that I can see that interlaminar line pretty clearly, even if the contrast doesn't spread down. So I can kind of draw that line down to my mind or even on the screen and use that as my landmarks for doing the procedure. And, as we know, we can also refresh the epidurogram as we do the procedure. And what we should see is that it should start to spread down, from above down into the level that we're working on as we decompress. And so I think that's a way to get the epidurogram out of the way, so the needle isn't going to cause a problem. And two, allow us to see how well we've decompressed the level by refreshing the epidurogram as we go.
Great answer, thank you. Dawood?
I have a question for Dr. Escobar. I think you did a really good job presenting the data and the streamlined technique. One criticism of the mild procedure I've heard from my colleagues is it's a procedure without a defined endpoint. What is your endpoint? When do you know to stop? When I first started this procedure, I would just do it until I looked at the clock and my arm was tired and it had been an hour and I said the procedure's over. What do you do to end this procedure? When do you know you're done?
Excellent question, and something that is always brought up. I like to look at each step as an endpoint in itself, starting with the epidurogram. We should have defined an epidurogram prior to coming to the case. Therefore, it should take no longer than 4 to 5 minutes to quickly get your epidurogram, and that's generous. The next step in the process is a single access entry point where we use the cannula. And that cannula needs to be docked at that interlaminar junction that's somewhat parallel to allow the rongere to get up and over that superior ridge. We have identified that 3 to 4 grafts or bites with the rongere at each level, both inferior and superiorly, on each side is typically sufficient enough as long as you're capturing enough tissue with that bite. So if you pull out your rongere and all you see is a lot of yellow fat, that's not an adequate bite. I wouldn't consider that one. So that's another endpoint, looking at 3 to 4 bites per lamina, inferiorly and superiorly. Then the sculptor itself should be passed no more than 2 times, using each pass with 3 to 4 bites. So every time you use the rongere, it's a single grasp and then clean the instrument. With the tissue sculptor, you pass that no more than twice, and with each pass, 2 to 3 grasps or bites of that ligament. A small change in volume is a large change in pressure. At the end, the final epidurogram in the lateral view is to safely administer my local anesthetic and a small amount of dexamethasone. So each of those steps are their own endpoint, and those done sequentially allow for an efficient procedure.
Great answer.
I really like that. That's really helped me to know that that's kind of a typical scenario. And when you go well above that or below that, you're not kind of within the norm. That does really help, I think, guide us.
No, I think the fact that Dawood's arm gets tired shows us he needs to go to Orange Theory or something. But that's another issue. So Dr. Weisbein, the question for you is this, though, and this happens pretty frequently. You have a patient that have multi-level disease. So you have an MRI, and you look at the MRI yourself, and you see a thick ligament at L3, 4, 4, 5, 5, 1. And obviously you want to make this as minimally invasive as possible, but you also want to make sure you do adequate treatment. How do you decide how many levels? And do you always do bilateral, or can you do unilateral and someone has one-sided symptoms?
I think those are really great questions, Tim. I think, to be honest, again, going back to looking at the image and basically evaluating yourself, the degree of hypertrophic ligament at each level. So, most people are going to have some area that's going to be more significantly impacted than the others. I tend to try and only do like 2 levels at a time. And I think the reality is, regarding doing it unilateral, bilateral, the new streamlined technique allows bilateral treatment to be done in a real simple and sequential manner per Alex's description. I mean, it's kind of one of those things that has enabled me to get in and treat these patients. For me, lately, the biggest patient that I found the most benefit from are patients who have had previous laminectomies or previous surgeries at levels below and then have developed stenosis above. And so having to treat those levels, sometimes you're only going unilateral because you don't have a lamina to fall down on to rest your device on. So I mean, it's just being careful and being cautious, but also looking and evaluating at what levels you find the most hypertrophic ligament, and I think those are usually the ones that are best treated.
Okay, great answer. Dawood?
Yeah, Dennis, you presented some interesting data from Dr. Priz's clinic about patients that had multiple ESIs and went on to mild, did really no better than the patient that just had one or no and went straight to mild. One thing I've heard, and I've seen it kind of anecdotally myself, is that sometimes patients will get the mild procedure and then over some time their pain may recur. Instead of repeating mild, you may consider doing an epidural. And I've heard patients say, hey, these epidurals seem to be a little bit more effective than they were pre-mild. Do you think there's anything to that, or is that just hocus pocus?
No, I think there's something to it. I mean, I did mild before, kind of had to go back into hiding and get behind the research before it could come back out within the last couple of years. And I have to say that I would do it on patients previously. They would do extremely well for a period of time, and then maybe they'd get some recurring symptoms. And at that point, I would look to try to do a simple epidural just to keep them out of going back to the OR and doing the mild procedure. And I would see that those patients would do pretty well following those epidurals, or they'd seem to last longer. So if before the mild procedure, if they'd only last, a couple months, maybe at this point it may last 6 months to a year. And I've actually, had a couple patients that during that hiatus would beg to have the mild procedure done again. And I have to say that since its reemergence, I've taken 2 of those back and I've retreated levels that I previously treated 6-7 years ago. And once again, the procedure worked very well and has done well for those patients. And so far, those patients haven't asked to have an epidural repeated because they're still getting relief of their lower extremity pain.
Yeah, Dennis,
can I add one thing to that, Dr. Deere?
Sure, Alex, I love that.
Dr. Patterson is extremely proficient and has done this, effectively to numerous patients. I think when we look at treatment algorithms, we want to really establish when is the right time for patients. So in my practice, if a patient comes back with recurrent symptoms, I'm not going to be eager to treat those patients. However, within 3 to 6 months, if they have not responded or feel like the symptoms have returned, that's where an interspinous spacer like Vertiflex would come into play for that patient. So I don't offer that to patients to tell them we're going to do this and then proceed with a spacer. I identify patients with ligaments and flavum hypertrophy, and in my practice, more than 4 millimeters. And if they fail to respond after 3 to 6 months or have recurrence of symptoms, I feel like that's where the interspinous spacer with Vertiflex fits a perfect fit. So, that's where I would employ these, and I encourage everyone to consider, utilizing the strategies that we have for the right patient.
No, I like what you said, Alex. I think that's a debate, right? I think Jackie said 2.5 millimeters, you said 4. I think the big key is the ligament compressing the spine. If it's a big ligament, but it's not compressing, then this procedure won't help the patient. If it's not that big, but it's compressing, it certainly may. So I think you just have to determine your own practice what's right. The last question I have for you guys, and Alex, you started the process, so I'm gonna have you go last because you just started the process of what I'm gonna ask you. I'll start with Jackie, then to Dennis, and to Alex. Give us a pearl for those out there who are fellows or residents. A lot of people are going to listen to this on the recorded version of this, so we'll have many fellows and residents. Give me a pearl of this procedure in just a few sentences that's important. Jackie, start with you.
Take time to look at your table and make sure that you understand how to get a good contralateral oblique. Not everybody does contralateral obliques in their training, and so it's a key part of this to understand what that image looks like. And you can adjust that. If your table has a bar, you can put like a pad on the table to raise that patient up a little bit so you can get that image clear. But I think to be able to do something proficiently, you have to understand what you're looking at. And if you don't have a good view, you're not going to be able to be successful in this.
Great point. Dennis, you're up.
I think the pearl that I would throw out there is, when can mild be utilized when Vertiflex cannot? And I don't know if a lot of people have ever sat down and thought about that. But as long as the patient has ligament flavum hypertrophy, mild can be utilized over Vertiflex when they have L5-S1 disease. They've got severe scoliosis where you can't line up a spacer between spinous process. You've got a patient who has osteoporosis or a Z-score that would probably make them prone to having a spinous process fracture. And then last but not least, just patient choice, somebody who doesn't want a piece of metal left behind in their spine.
Oh, great pearl. Alex, the last pearl, and then we're gonna end the session.
All these pearls, it's hard to come up with a unique one. I'd add to what Dr. Weisbein said in terms of the epidurogram, doing an initial diagnostic ESI for these patients and then saving that CLO view is imperative. When you identify actual buckling of the ligament, it is reproducible, and those patients seem to do far better than any other patient that I've seen. So when you're doing the CLO view, and if you see a classic thickening of that ligament with buckling, those are patients that are getting a mild procedure right when they leave. I think I gave one more in that we can utilize this technique for bilateral spinal stenosis as well as multi-levels. And with the single access, we're able to treat multiple levels at the same time. Whereas with reimbursement changes, I think utilizing other options may become more difficult. This is allowed to be, utilized in your hands. So it is effective as you allow it to be.
Oh, great points. Thank you all so much. I think
Job,
it's
guys.
a great session, and we really appreciate all three of you. Thanks so much.
Fantastic
Dawood,
job, everyone.
You're up, Dawood. Next session.
Yeah, great. So now we're going to pivot a bit and get into our Shark Tank session. So first, we're going to have the BioTras team discussing their platform, which is really a cool and unique, innovative way to do hands-on training. Jennifer, please kick it off.
Okay, can everybody hear me?
Yes.
Okay, great. I don't have much of a presentation. I really more here as the new gal in town, and just I'm the creative person. I'm not a doctor, so you guys, a lot of stuff goes over my head. So anytime you have questions for me or requests of me, what I want is just talk to me like you're talking to a patient is what I can ask for. So I think Dr. Nelsen and Stevens probably have a little more specific information about what their applications are with our models. But I can say that just about if you can think it up, most of the time I can try to recreate it. So I'm excited that a lot of device companies have been in contact with us as far as creating new models.
Jennifer, sorry to interrupt you. There's several people out there who may not know what you do.
Okay, sorry.
So could you go back to like kind of the basic level, what BioTras is? Because I think really, to a lot of folks, this is a brand new concept.
Sure. So basic, we are simulated cadavers. And the really cool thing about what our cadavers can do is I can do specific parts. And we can always make sure that whatever ailment needs to be recreated over and over again for the sake of training can be recreated over and over again. With a traditional cadaver, you never know what you're gonna get, but with our models, it's consistent. It can be tailored specifically. It can be, I have pelvic models, arms, legs, shoulders, full torso, and we have recreated the epidural space. So being able to practice procedures within the epidural space, we've been able to recreate that, which is huge in the pain management world, obviously. And so that's kind of in a nutshell what we do.
Jennifer, I have a question.
Sure.
I have a question for you too. So I think a lot of this is, what is the need for this? And I've been doing fellow teaching and a lot of other educational events for about 10 years, and Tim's been doing it for 20 plus years. And we've used human tissue and cadavers quite successfully. What's the value add of using something like BioTras versus the standard what we've used for years and years? And what are some of the, you kind of mentioned some of the advantages to using a BioTras model, but what are some of the disadvantages or cost with going how we've always went?
Well,
I'm
go
sorry,
ahead.
I apologize, I was late. I thought I wasn't on for a little bit, so.
We're a bit early. How are you, Dr. Nelson?
Yeah.
Thanks for joining us.
A little bit about how I use the models at the Brigham and Women's Hospital in Boston, if you want to hear about that, and then maybe Jen can answer some other questions about cost. So
Yeah,
sorry, but I'm Ehren.
Jump on in there.
So over the past couple of years, I started this interventional pain simulation lab here at Brigham and Women's Hospital at Harvard Medical School in Boston. And so BioTras donated a couple models so we can incorporate into training our fellows. We have a pretty big fellowship. We have 10 fellows a year, plus 2 to 3 pediatric pain fellows at Boston Children's Hospital who participate in our program and rotate through our sim lab. And so I'll talk about a little bit about the simulation-based education that we've been developing. Next slide. And so this is just one of the cadavers we use in our model, in our curriculum. Next slide. So simulation-based education has been around for a long time in the medical field. So it just can be defined as any device used to mimic a realistic patient interaction or experience. And so this all started maybe 3 decades ago, where the anesthesiologists took tips from the aviation industry to create a crisis resource management system to integrate into their curriculum so that they can practice critical but rare scenarios. And over the past 3 decades, that's just expanded in use from like using simple mannequins to high fidelity interactive mannequins. And then now with so many subspecialties and advanced procedures and techniques, a lot of task simulators are available. And so those are available for angioplasty, interventional radiology, echocardiography, endoscopy, you can name it, there are tons out there, spinal cord simulators. And so it's becoming very common. And so we kind of took some notions from that and incorporated into interventional spine using fluoroscopic spine-based procedures. And this is one of the models we're using. Next slide. And so what this model is something that in medical simulation we call task simulation or part task simulation. So you use a focused part of the human body to serve as a model to teach a specific technique. So whether that's suturing, airway control, IV placements, angioplasty. It's just to train on a specific technique for your learner or trainee. And there's lots of research that's been done over the past 20 years and even more coming out that show improvement in performance when you subject your trainees to some type of simulated environment or procedure. Next slide. And so it gives our learners and trainees, so our fellows in this case, a chance to practice these procedures in a way that they can improve their skills. But it also gives us a mechanism to identify knowledge gaps and performance gaps. So this helps us create a curriculum and tailor it to fulfill those deficiencies or gaps that we find in the trainees, whether they're residents or fellows. And as people present more data on using this type of simulation in their subspecialty fields, we're gaining some insight into how useful they might be as performance evaluation tools. It's kind of like a natural evolution of using simulation in medicine, where you're just practicing, doing research, and then you kind of move up to tailoring your curriculum based on results from your sim labs, and then finally performance evaluations. And so just a couple of things that we know from years of research is 3 things that are incorporated into the sim sessions to make it more effective, and that's repetition. So giving them the opportunity to try these things over and over again, integration in some type of formal curriculum, and then the most important would be some type of debrief. So you have to, when you run a sim lab, you have to have a formal debrief session so the learner can review what they did, what they missed, and allow the instructors to help them identify those factors. And so, like I said, for the past 3 years, we've been developing this interventional pain simulation curriculum here at Harvard. And it's been an interesting process. And we use these BioTras models. That's why they asked me to speak tonight about kind of how we use them. Next slide. And so essentially, this is how one of our sim labs is set up. So for our fellows, we usually try to do 4 or 5 sim sessions early on in their fellowship year. So August, September, we try to get 5 sessions done covering basic bread and butter pain procedures. So TFSEs, interlaminar ESI, cervical, lumbar, cervical and lumbar RFL, sacral transforaminals, maybe some SI joint stuff too. And we try to get those done. So we just teach the basics, basic skill set, tips and tricks on how to perform this procedure, safety considerations, and then radiation safety is a big component of what we teach too. Not only increase efficiency of the fellows, but to reduce the radiation exposure that they, subject their patients to and the staff who are training them. So for each individual session, the basic setup is we have them fill out a survey just to identify how many times they've performed a certain procedure, how comfortable they are. And then we bring them in the room and have them perform a procedure like they're a solo attending in the room one-on-one with the patient. And then we record objective metrics. So certain easy things to do are procedure time. So how long does it take them to perform a simple transforaminal ESI? And second is how much radiation do they use? How many fluoro images are they taking? What's their fluoro time? And what's the total radiation dose for that given procedure? And when they feel like they've completed the procedure, we do our formal debrief, didactics. We give a lecture on how we perform the procedures and then safety considerations and best practices. After all the fellows complete their first attempt at the procedure, they get to do it again. And then we compare how they do before and after. And we can compare those metrics. And then we have them fill out a survey afterwards. Next slide. And so, as you might expect, letting fellows train on this will improve their scores in any metric that we use. So their procedure times go down, their number of x-rays they use goes down drastically, and they increase their procedural accuracy. And depending on the degree of experience of the trainees, so we get fellows in August and September, some have never seen an S1 TFSE, some have seen it 100 times. But it's still universally they get better with these simulation labs. And then on the subjective side, almost all of them enjoy it. So 100% of them call it very helpful. And they all feel more comfortable, at least running through the sim lab for each of these given procedures. Next slide. And so not all of these procedures are amenable to kind of collecting data on how quickly they perform because it's just not efficient. So DRG is an example of something we're not going to let them come in and try to do a DRG lead. We would just all get radiated and get cancer before anybody finishes fellowship. So we just set up skills labs where the fellows can come in, and we have 2 of these cadaver models and 2 floor rooms that we set up in our sim lab. And so we split the fellows up, and then they all get a chance to get their hands on this device specifically because it's a little bit more technologically advanced or a little bit more complex than standard pain procedures, even than dorsal column stim. So they get a chance to use access the epidural space, use the introducer sheath, figure out the mechanics of the sheath and the lead and the stylet and when to lock, when to unlock, when to move the sheath. So all these mechanical things are great for them to pick up and learn before they even get into the OR. So it's a little bit more streamlined. And plus they get a little stressed in the operating room because there's OR time and you can't take 3 hours to do one stim. It just doesn't work that way. So they really appreciate that. And so these are a couple of pictures of that lab. You can go to the next slide. And this is us using the BioTras cadaver model. So these are 2 different fellows putting a L1 DRG on the right side, putting the context under the pedicle and out into the neuroforamen, throwing some loops up and down. Next slide. And one of the nice things is, once they're done with the procedure, we can debrief and talk about how they did, and then we can pull up the skin and kind of just show the trajectory of the lead going through the interlaminar space or the epidural space. And on the lateral view, you can see it coming out of the dorsal root ganglion space so into the neuroforamen. And so the fellows really, really appreciate that experience. And I'm an academic, so we try to publish on everything we do. And so we don't collect objective data from these skills labs, but we do surveys to get a sense for what the fellows feel about how the skills labs are helping their process through the fellowship. Do they find them helpful? Do they want to do more? And so we always collect this type of information to help tailor our sim curriculum going forward. So next slide. I think that's all I have. Just to kind of give you an overview of the sim curriculum we've created. And we do use the BioTras models, so I can answer some questions on how we use them. But
yeah, so I think that was a great job. I've never seen this model in person. I think it was really interesting to see you use it with fellow training. I remember early on the simulation models for anesthesia were very stressful. So this is a big advancement. How easy it is for this to, let's say, for example, we wanted to train people during COVID, during this pandemic. Hopefully there won't be another one, although there was a bubonic plague case in California today. Dr. Chakrabarty, I hope you're safe. But can we move this model around from my practice to train a couple people here and then to Dr. To Dawood's practice? Is it easy to move this around, or does it need to be like a simulation lab like yours?
So they're easy to move around. So actually, over the past couple of years, we've actually made suggestions on how to improve it, like creating the neuroforamina. So we ship them back, and then they ship them back to us. So they're pretty easy. They're really heavy, okay, but they're easy to move around. They can be shipped around.
Okay, that's helpful.
Yeah.
Krishnan, you have a question?
Yeah, this is maybe more of a perspective. It was interesting about a couple years ago, there was a push to make pain a separate residency program because there's an increasing number of new skill sets. I think one of the things is that, do you think that BioTras and these kind of easier ways of accessing certainly models can help in kind of developing better curriculums in the 1 year time frame that we have to train fellows? And we always get this in an academic center. You just feel that 1 year is never plenty of time. So do you see this kind of becoming more of a mainstream academic use for training in the near future?
And I certainly see something like this. So whether or not we incorporate some type of performance evaluation tool at the end of fellowship to pass certain metrics before they can be practicing pain positions, I think that's better for our specialty so that there are less complication rates. I think, yeah, I agree. 1 year to do this fellowship, our fellows want to do research, but they don't have time because they have to learn so much psychiatry, so much physical exam, neurology. There are just so many things, not to mention all the new procedures that are coming out like Vertiflex and mild, in addition to stim, and you're doing pumps. That's a lot to learn for 1 year fellowship. So I think at least this can offload some of the numbers you're trying to get for procedures to have a sim lab set up like this, and maybe some kind of structured performance evaluation would be something we could move to at least guarantee some competency of the fellows before they graduate.
Interesting.
Well, great job on this, Dr. Nelsen. I think this is really a unique way to train your fellows, and we're going to invite Dr. Stevens now to talk about how he uses BioTras in his practice.
All right, well, thank you very much.
Thank you.
Thank you very much, Ehren. Great job.
Can everybody hear me okay?
We
Yes.
can.
All right, good. Sorry, we had a little bit of technical difficulty here. So super excited to be on the call tonight. Thank you for asking me to be part of this, and thank you to BioTras for inviting me. And so I wanted to just talk a little bit about something I'm pretty passionate about, and that is getting a chance to teach labs to other doctors and try to kind of, as iron sharpens iron, work together to make each other better. I think there's a lot of good that comes from these labs we have, but sometimes having a lab can be a little bit tenuous or a little bit troublesome. And so always looking for the best and easiest ways to perform a lab and get the results we're looking for as far as the training without having to make a big mess. So that's one thing that's pretty cool about this device. So next slide, please. So when you look at this little breakdown here, when you look at what cadavers can do, we all know what they can do. We've been through medical school, right? And we know what we can expect when we have a cadaver. We know that there's a smell. We know that there's some other things that have to go along with that. But one thing that you don't think about maybe is when you're having a cadaver into your facility, you're potentially going to be inviting disease into your facility. And so, especially in light of the COVID and some of the things that serology testing and other things that have to be done in order to get a cadaver into a facility, it may slow down your lab or your ability to perform a lab. And so BioTras offers some other things that will help you there. So you've got these anatomical reproductions in a way that you can teach somebody very easily without having to make a large mess and have a lot of cleanup. And so these can be customized, which is one of the stars here. These don't have to require medical storage. They have no smell, which again, we all went to medical school. We know everybody at church knew how we smelled when we walked in. And they can be shown on a C-arm and easily demonstrate a procedure. So very good alternative for training. Next slide. So when you look at this, this is a company that's founded out of Dallas, Texas, which I'm a little partial to since I'm in South Lake near there. But John East is a doctor who thought this was a reasonable way to train. And so the mission of BioTras is to revolutionize didactic cadaver training by enhancing physician expertise and reducing training costs. We all know that there is a large amount of expenditure in all these labs that we go to every weekend. And we know that by going to these labs and teaching other colleagues, we're going to make them better physicians and we're going to help more people, but there's cost involved and there's effort involved in getting that cadaver to the facility. And then again, we have the serology testing that has to be done. And then just the fear some facilities have of bringing a cadaver into their facility. And so this takes away a lot of those issues. This is a training system that simulates anatomy in a sense that you can have all the way up to actual bone over with a gel topping over the top, or you can have a artificial bone, but either one can simulate the procedure well enough for a doctor, as you've already heard from a administrative training standpoint in a academic center, that you can use these to train your physicians to do procedures, and it can be done reproducibly. Next slide. So these are just a list of a few things that we can do with this. And so this is kind of the entirety of my practice and most of your practices. So anything as simple as an epidural injection all the way through doing this past weekend, we did a SI joint fusion course and we were able to use the device for that. I remember the first time they told me they were going to come train me and they were going to use this device, and I thought it was kind of comical. And then we put it underneath the fluoroscope and the anatomy was very realistic, and I was able to train in a few minutes in my office and clean up in about 2 minutes. And it was really awesome for that standpoint. And then we're training people this weekend on it. So some doctors are a little worried about coming into these labs, being with other colleagues and things of this nature right now. And maybe some people are a little afraid of being around a cadaver. This takes away that concern. So you can even do treatments like more advanced interventional procedures, such as the interspinous spacer placements we've talked about, the SI fusions, the decompressions, interdiscal injections, radiofrequency ablation, and the anatomical model can be accurate enough to give you the same kind of feeling you have going through tissue and then getting onto bone and or, you know, between bone, whatever the case may be. So I was a little skeptical, I'll be honest, when I started using these. But now with the ease of use, along with the reproducible good results we're seeing and patients being able to get helped, even though we have kind of a pandemic going on, I've become a believer. So this has been a great addition to my practice. Next slide. So I think we already mentioned that you can actually see pretty well with your C-arm and ultrasound and even MRI imaging with these, and it looks very anatomically accurate. It's remarkable how accurate it is. And I like to give a little bit of feedback here and there. I'm on their advisory committee and can give them some feedback about things I think would work better. But by and large, the bone anatomy you're working with is very easy to visualize, very easy to place needles and or cannulas on. And I think you'll find that your doctors you're training will feel that it's very much satisfactory as far as then going on and treating real patients, and just as if they had been treating cadavers over the weekend and go on to real patients. So I think it's a good alternative for us to be looking for in the future, especially as medicine evolves. And what we're seeing now is our very large training centers and labs are becoming smaller and more regional and more local. And maybe this is a way to have our trainings and still have effective, you know, expertise for our other doctors without having to go and you know, rent a cadaver and make a big deal at some surgery center. Next slide. So this is just some different things. You can see a person in the upper corner using it for a kyphoplasty technique. You got next to him is doing an SI joint fusion. And you can see all these people standing around, and you can see in the bottom left quarter there, that's what the anatomy looks like. It's very realistic. It is very well represented with the C-arm, and it gives the doctor the sensation that they're performing the procedure. And I think that you'll find that with the ability to melt these down and make new ones, you can reproducibly make the anatomy the way you want it. You can alter it by making a disc herniation if you want it one time and not another time. You can make an SI joint tighter, or you can make it more distracted. There's a lot of different things you can do by giving suggestions back to the company. Next slide. So again, this is just a really nice model here that shows you some actual hardware inside of this back, and you can see this looks extremely realistic. And when you're working on some of the procedures we do on cadavers, you don't always get the perfect cadaver. Sometimes you get a person that's got some anatomical variants, which make teaching a little more difficult. And so you can either simulate more difficult cases and show people how to get around some of the struggles they might have, or in some cases, you can go and you can put this hardware in there just to give them a chance to see what it would look like to work your way around it and go underneath it or over it. And so I think that's a nice adjustment you can make. If you want your nerves to be large and involved in touching the other tissue and structures within the facet or the foramen, you can do that. You can put these pedicle screws in. And so you have an option to even create a scoliotic spine, because we all know that we don't get perfect spine patients when we do a procedure. So I think you can kind of custom make your patient. And as we all know, anybody who teaches that's on this panel, everybody that does this, you've gone in and you've seen a cadaver and known right away it's going to be difficult for the people you're proctoring to complete the procedure on it. So you know what you're getting into with this. You get into this procedure and you can already know ahead of time any downfalls or pitfalls you might have. So I think that's another advantage. Next slide. So this is just me this weekend, and you can see a picture of the sacrum we worked on. Obviously, we were wearing masks and we were social distancing and doing all the important COVID requirements. But you can see that this is a cannula that's easily sticking into that gel and staying in place as if it's human tissue. And so I was a little skeptical of that again, but you can actually ask them to make that harder and make it more taut so that you can hold instruments in place. So there's a lot of variations you can do with this. And I think you'll find if you start to add this to your fellowships or to your training programs, that your doctors will be getting great training without a lot of the mess and a lot of the struggles of getting the cadaver in the building. So give it a look, give it a try. I think you'll be pleased. And I hope everybody on the webinar gets a chance to get their hands on one of these models soon. Thank you very much for having me on tonight.
Chad, great job. Certainly enjoyed your insights. I have just a quick question for you.
Yes, Tim.
You know, I recently had a case where I was teaching something to some really high-trained people, and it turned out the cadaver was still frozen in the epidural space, which we didn't realize at first, but it made it very difficult. I initially thought their skills wasn't great. Turns out the cadaver was still frozen. So they were very skilled people, and they did a great job later in the day as an unthawed. So I do see the value of this. And I enjoyed your presentation and that of your colleagues. The question I have for you is, what's a negative about this? There's got to be a negative. I mean, you both present a lot of positives. Tell me the negative.
So, I mean, one negative is just like any cadaver. Once you've already, gone into the tissue or gone into the bone, you have to replace it with another one, right? And so it takes a minute to change out. Like in this case, we had to change out the rear and find another rear. And but just very simple, in a lot of times when we're doing that in the lab, we have to go find another frozen specimen, bring it in, thaw it out a little bit, and we have to wait a minute. This is just an immediate, you set it on the table, remove the other one, put it on the table, and you're ready to go. So I don't really see a lot of downside to that. I don't really have a downside to say. I haven't run into anything yet where the anatomy wasn't real enough feeling that I could do it. The next thing we're going to talk about tonight, Spinal Simplicity. I also had a model like that I trained on initially for that. Again, during COVID, it was a little bit easier to do little local trainings than it was to meet in big groups like we're accustomed to, Tim. And so that would be the only negative I think there is. And then the other thing is, maybe if you're teaching your other fellows or your other doctors something specifically, you might through time learn how you want your cadaver to be made so that you can make those physical differences and manifestations so that you can teach them a more specific approach or something.
Perfect. Thank you very much. Gentlemen,
Sure.
Any other questions before we move on to Spinal Simplicity? I think of Chad. I think this is going to be the Chad Stevens show tonight, so we're enjoying it. So now Spinal Simplicity is up, and I think you're up for that as well.
Yeah, great job.
Thank you so much. Appreciate it.
Great job, Chad. So our second think tank session will be Spinal Simplicity, and we'll have Dr. Moseley, who's CEO, or not Dr. Moseley, but Todd Moseley, who's CEO and co-founder, as well as Dr. Hochschuler and Dr. Stevens, who's on our last panel. Gentlemen, please.
Dr. Sayed, Dr. Deere, thank you guys so much for having me on. I'm Todd Moseley, CEO and co-founder of Spinal Simplicity, and just want to say I don't know that I would ever actually be here at this point in time if it wasn't for your all's invite last December to your meeting in Scottsdale. So thank you guys. You kind of opened our eyes to a market that we probably underestimated, and I could not be happier to be here at this point in time, so thank you so much. Spinal Simplicity is a revenue stage company. We have 3 FDA clearances to date, as well as our CE mark and our Health Canada approval. We've developed a proprietary solution for lumbar fusion. We have 75 patents issued, additional 25 patents pending. Next slide, please. Spinal Simplicity is a medical device company focused on the design, development, and commercialization of innovative spinal and orthopedic implants, founded in 2008 by my partner, Dr. Harold Hess, and myself. Our vision is to be the global leader in innovative, simplified surgical solutions. Our mission is to provide exceptional value to our patients, our physicians, and our payers. And the values that drive our company every day are integrity, patient first, relentless pursuit of perfection, and teamwork. Next slide, please. A little bit about our advisors and here's our management team. So I've spent my whole career in the med device space, the last 32 plus years. I exited my last company, built it a little over 60 million before I exited to focus on Spinal Simplicity full time. My partner, Dr. Harold Hess, is my co-founder, neurosurgeon, and co-inventor of the technology. John Hess is my VP of Business Development and Director of Finance. John has literally held every position in the company, including my own. He's our first employee. Melissa Frock is our Director of Engineering, has been an absolute rock star for us. Roger Yap, most recently was Senior VP of Sales at Invasive, and we're thankful to have Roger on board. He's got 25 plus years experience bringing new technologies to the market. Next slide. This is our advisors and our consultants. I also like to talk about this as our exit team. Dr. Brad Paddock has most recently been president of Stryker Spine Division. Before that, he was VP of Sales at Kyphon. Charlie Federica most recently was chairman of the board of Mako Surgical. He orchestrated that $1.6 billion acquisition by Stryker of his company. Gary Henley, he's been CEO of Orthofix, been CEO of Wright Medical, past president and CEO of United Orthopedic Group. Gary may be one of the most sought after board members in all of orthopedics and spine. Thankful to have him on board. Rich Grant, you guys probably know his product or seen it around the hospital, but it's the O-arm. So Rich developed, he was the CEO of Breakaway Imaging. He sold his product, the O-arm, to Medtronic. I think Medtronic sold another $850 million of his product since then. Next slide, please. A little bit about our technology. So the Minuteman is a minimally invasive interspinous interlaminar fusion device. It's intended for immediate rigid stabilization of the lumbar spine. It fixates to the spinous process, providing immediate stability. It's most appropriate for L1 through L5 with this G3R version, and it's intended for use with bone graft material. The implant is coated with hydroxyapatite. We were the first company in the spine to get HA FDA clear for this application, and it just really aids you in getting an immediate rigid fixation because bone adheres to it very quickly. There's some fusion images on the far right. The image on the bottom right is from our European device, our first generation product. Next slide. And so now I'm going to introduce Dr. Steven Hochschuler. He's our co-founder of the Texas Back Institute. He's been an orthopedic spine surgeon for 40 plus years. There's no way I could list out his bio. He's also a U.S. military veteran, a major in U.S. Air Force. His contributions to spine are enormous. You can't go anywhere in the world and not run into someone that knows Dr. Hochschuler. So with that, I'll let him take it away. Thank you. Dr. Hochschuler, are you there? Well, I guess I'll keep going and see if the good doctor joins us. But so a little bit about our design of our implant. So that threaded body gives you a huge mechanical advantage over the space. So when you lock that down, it's comparable to 4 pedicle screws and 2 rods. So the best, maybe an example of that is a scissor jack on a car, that you can lift a 4,000-pound car with a scissor jack. And very similar to this mechanical advantage you gain with the threaded body, it gives you a huge advantage over the space. You can also notice we have a large graft window. So our implant will hold majority of the time more graft material than the typical T-lift cages on the market. Next slide, please. So in the clinical side, We've had a multi-center trial in the UK. So I'm getting some feedback there. So this study, we should have the full abstract from it, first full year results, but basically we compared our device standalone with bone graft material to full surgical decompression and open laminectomy. I don't know if you guys can hear that feedback, sorry about that. And what the paper is showing is that, our initial goal was that we would show equivalence to the gold standard, which is the full surgical decompression open laminectomy. We're actually showing superiority to that. We've had no reoperations in our group. There's been several reoperations in the full surgical decompression open laminectomy paper. We also have a paper, we compared 100 of our patients to 100 Coflex F devices, and Professor Alexander did that study for us. So next slide, please. So in the UK, in that clinical trial, it showed a dramatic reduction in surgical time, length of stay, and blood loss. So the blood loss in this procedure is averaging about 5 cc's, about a bottle cap full of blood. Next slide, please. So this is the paper that I was referring to. We compared our device, Dr. Alexander did, Professor Alexander, 100 Minuteman to 100 Coflex, showed about an 86% fusion rate with the Minuteman device, that the patients returned to activity much faster than they did in the Coflex study overall. Next slide, please. So a little bit about our pipeline of technology. We're certainly not a one-trick pony. We're recently developed a product for C1 fixation. So it'll take the place of having to place lateral mass screws at C1, and then that a doctor could easily attach a 3/5 posterior rod and screw set with that device. We have a cervical plate based off Wolff's Law technology, and that simply states that if you stress bone, obviously bone reacts by laying down additional bone. This plate provides full-time active compression, almost 12 pounds of load, 24/7 until it's fused. We can take that same technology and place it in foot and ankle plates as well. And at the far left is our European version of our Minuteman, which soon is going to be available in the US. I'd like to introduce Dr. Stevens now. I think you guys were just with him, but he's going to walk you through the Minuteman procedure.
Okay, I'm back. So those of you that know me know that I get a little passionate about things I'm talking about. What we're looking at here is a device that has an indication for spondylolisthesis, degenerative disc disease, and or trauma and tumor. We're going to show you just a little video that's already playing, obviously, but what you're looking at here is your spinous processes posteriorly, and you want to go down to the spinal laminar junction with the guide wire. That's what you're seeing happen here. You'll notice that the supraspinous ligament or interspinous ligament is not damaged in any way. The device goes through the anterior third or so of the interspinous ligament there. And you can see that you have a series of dilators that you put in, followed by this tissue rasp. And then this is the tap. And this is how you decide what size you're going to use, the 8, 10, 12, 14, and so on. And it's very simple to place in. Once you decide on your implant, just like any other implant you put in, it's just putting the device in. So you'll see this now. One thing we really strive to do with this, we try to make sure that we get the device put in as anteriorly as we can, as close to the spinal laminar junction as we can, to give the patient the best fixation and the strongest part of the bone. And those of you who have done studies with other products know that that's the strong part of the bone. And so there's a few little fine niceties you do to do some twisting to get the device to bring the two spike plates together around the spinous process. And this little device is so cool. It's kind of heavy and it's fun to hold in your hand and kind of twist, and it makes you feel like you're doing something. And then you go through and once you've deployed the whole device, you release it and you're done. That's what it looks like. So what I want to impress to you is a little story. Basically, the reason we have meetings like this and the reason we're all into this is because when we get on the phone together, we get in a webinar together, or we meet in a setting where we can learn from one another, what happens is we grow together. And so one of the members of Aspen, Doug Beal, reached out to me and said, "Hey, Chad, you've got to meet this company. You've got to try this product." And the story went on that I got a hold of Todd and Roger, and Todd came out and trained me. And it was so impressive to me that the CEO came out and actually trained me himself. At first, I got to be honest with you, I thought it was kind of weird. I was a little nervous. This guy's coming out, but then when I realized that this guy invented the device and could put it in faster than any physician on the face of the earth, I decided that maybe I should listen to him. And so as we started doing this, I wanted to debunk two different rumors about this. Number one, I thought for about 5 seconds before I did it because I heard it was too difficult. And within the first case I did that was in just around 20-minute time frame, I realized that is not necessarily a true rumor. And at least so far in my hands, it hasn't been difficult to get in a time where I'm consistent with other procedures that are similar. Number two, this rumor is that it's really hard to place the device laterally. Now, I'll be honest, it's the first device I've ever placed laterally, but after doing it in a cadaver, and those on the panel, you know, Dawood had a case today, and I know Tim has been trained in doing these, and you guys, you know what I'm talking about. Once you've placed that guide wire in, it's just handing dilator over dilator, right? I mean, we could teach a medical student to do this once they get the guide wire placed. And so the rumor that it's a difficult procedure is wrong, and the rumor that it takes a long time is wrong. A couple of things you need to know about Dr. Abrani is a well-known name who has got an opinion about this. He said, we found this new and innovative Minuteman device very promising. We have reasonable experience with the interspinous distraction devices. The Minuteman has been very different due to the ability to form a fusion. I think we all understand the significance of that. It allows us to do the treatment of a lesion or a level where there is a spondylolisthesis or a slip. And I think that we know of limitations with other things we use because of that instability of the lumbar spine. And we want to do the very best thing we can for our patients to give them the best outcome, the shortest amount of time. So Minuteman's advantages, according to Dr. Barani, are short surgical time, like I've already alluded to. There's minimal surgical pain, which I've found to be the case, minimal blood loss, short hospital stays. We're doing these outpatient. The patients are leaving 30 minutes after their case is over. So far, I've found the effective reduction in pain that he's talking about. And then what we've got is some data that Todd already alluded to that said that this is equivalent to the strength of rods and screws. And we all know people that fuse with rods and screws reproducibly. So why not do something? My question to the people I talk to is, what do you do the rest of your day? If you're used to taking an hour and a half to do a fusion, what about being done in 30 minutes? What are you going to do? Go golf? Go guns? I mean, figure out a hobby. Heck, go see your wife and reintroduce yourself. You know what I mean? So it's a quick procedure with lots of good results. Next slide. I mentioned Doug earlier. Doug is one of those guys that I consider to be a mentor for life. Doug and I met many years ago, and I don't take very many steps without talking to Doug Beal. And I think that's true of everybody that's on this panel and a lot of people that are on this call. He's a grandfather to us. He's not that much older than us, but he is well known to be somebody who tries things out and is very ethical in his approach to medicine. And so when Doug called me and said, Chad, I got something for you, whenever he does that, it translates into, I'm going to be doing this for a long time and a lot of them. And Doug's take on this is Minuteman is revolutionary technology, allows the fusion stability through a minimally invasive lateral approach that produces surprisingly little postoperative pain. My patients are in and out at very little time, achieve postoperative improvement almost immediately. Everybody that's on this call knows that Doug doesn't fabricate results, right? He does multiple procedures, does multiple paper writing, and he comes out and gives people the honest truth. So we have the placement ventral, the supraspinous ligament is key for stability, and the implantation kit makes it easy for use. The Minuteman is one of those devices that after you use it, you can't imagine not having it. So next slide. So there's some highlights here. I think Todd's alluded to some of them. By the way, Todd's humility is ridiculous. So I'm trying to learn from him, but just having a CEO who has brought this to market and who can do this procedure, and yet every room I have him go into, they talked about his humility. It's a real blessing to work with a company like this. And so if there are people out there that want to get trained on this, man, it's time. Part of this talk tonight is to say, forget about the rumors out there and get busy doing this procedure. Your patients need you. Your patients want you to do this, and it's well within the scope of your training and your capability to do this. And so there's clinically validated 8 years of successful outcomes. There's 75 patents issued, And believe me, Todd's, when he's not thinking, he's thinking. And when he's not sleeping, he's thinking, because he's got lots of ideas. There's a lot of people that have been, opinion leaders for them that have already voiced their opinion. I'm becoming a big fan of this product myself. And I think those of you on the panel that have done it would agree that this is going to be one of those things. We have all different tiers of pain doctors' skill sets. And I think this is going to be something that everybody's capable of doing, but some people are a little intimidated of. But I want to encourage you to get the training. I'll come train you, or somebody will train you to get you up to speed so you can effectively and safely do this procedure. Because again, you have a lot of patients out there that need this. There's patients that are getting other treatments that may not work as well as this might. And I mean that, big fusions with longer recovery times and things of that nature. So I would encourage those who are on the call to learn more about this device and get busy doing it. Next slide. That is our final slide. And I'm speaking about BioTras again, it looks like. So thank you so much for having us on the call tonight. I really appreciate the time and attention. And I just want to encourage you guys that these two things I talked about are things you need to add to your regimen of what you're treating patients with, so that you have more tools in your bag and you can get patients better faster.
Todd and Chad, Dr. Stevens, thank you all so much. That was really insightful. I think Stevens, you're a little bit humble. I do believe that putting the pen in is the initial skill that you have, based on all the years of experience you have. But I do think we can train fellows and residents to do this procedure quite safely. Before we close, I think Dr. Dawood Sayed has a question for Dr. Hochschuler. So Dawood, I think you have that question.
Dr. Hochschuler, I don't know if you've, sorry for the technical difficulties. Are you with us?
I am, but I can't. You have me muted.
Oh, we can hear you.
Okay, now I'm unmuted. Good. Now, I've been here all along. I don't know what the problem was, but I thought the presentation was fantastic without me. So you really didn't need me. I would only say this. I think, as being a spine surgeon and one of the first out there, I think things are shifting in the spine world, just like cardiovascular way back when. And so the shift is really going to be away from the surgeon to the interventionalist. And you guys are the interventionalists. Any argument that people have, and Vertiflex asked me to help them, I didn't really like what they had, to be honest with you. I'm not here bashing anybody. I like the fact this is interlaminar. It's low. I like the fact that I'm told none has had to be retrieved. I like the fact that this is not just an interspinous or interlaminar device, but it's a fusion. I like that it's fast. I like that it's safe. And any arguments anybody would have that an interventionalist should not be doing this, they're crazy. You guys put in dorsal column stimulators, you put in pain pumps. This is much safer than either of those procedures. So all I would say is I rarely join other groups now helping with a project in terms of new technology. I'm usually looking way downstream. So now I'm looking at regenerative medicine, rolling up all sorts of telemedicine phenomena. I helped Harvard set up telemedicine 40 years ago. I was 40 years too early. So you can be too early. But right now, it's not too early for any of these things. And minimally invasive spine surgery, as you well know, is the way to go.
No, thank you very much for those kind words, and we apologize that we muted you earlier, but with all the innovative things you've been involved in, we hope to invite you to our think tank next year to present to some of this other interesting work that you've been doing. So we really appreciate that, and we really appreciate your insight as a spine surgeon weighing in on some of the political battles that we will be fighting as we adopt these therapies.
Just like Washington, forget the politics, do what's right.
I love that. Yeah, we're honored to have you tonight. So thank you for those comments. It really means a lot to all of us.
Thank you.
Thank you very much.
There you go, guys. You got the blessing from a well-known, renowned spine surgeon to say it's okay for pain doctors to operate. Don't be afraid.
Yeah.
Do it.
Oh.
All right. Well, thank you very much. Dawood, I think it's time to wrap up the session.
Yeah, absolutely. So, this was really a great 5-part session. Again, unfortunately, we're not able to do this as originally planned in the Bahamas, but I think we really did the next best thing. So thank you, everyone. We look forward to having everyone together again in this similar format in September at our annual meeting, and then hopefully an in-person meeting sometime soon in the springtime. Thanks, everybody.
Thank you.
I'm Dr. Tim Deere.
And I'm Dr. Dawood Sayed. And we're excited to be hosting the American Society of Pain and Neuroscience's annual virtual conference, broadcast live from Nashville, Tennessee on September 18th